everyone, welcome to the MI Mental Podcast, the Doctors in Court edition. My name is Sabine Fonderson. Today I'm diving into a case that's both educational and eye-opening. So quick heads up, all the names I use are fictional to protect the privacy of those involved, but the cases are real. So if you're a healthcare professional or you're just interested in medical ethics, I'm hoping that you're going to find this session really thought-provoking. And for those of you who might not be familiar with medical court cases, I'm going to break down each part of the story, starting with the timeline. Then I'll move to the plaintiff's case, the defense case, and the court's decision. And a little extra, I'll explain some medical jargon and get some in-depth discussion about what the real case is about. Our story begins with Mrs. Evelyn. She's an 89-year-old woman who's been dealing with rheumatoid arthritis. She's been on prednisolone for many years, and that's a steroid that helps with inflammation. But it also makes the skin fragile and makes it more prone to injury. Around 18th of October 2006, Mrs. Evelyn had a little accident, and she got her leg caught between her walker and a chair. And that accident caused a hematoma or a bruise, and soon it turned into a blister on her calf. On October 26th, she goes to see her GP, and I'll call him Dr. Casper. He decides at that moment not to open the blister, which makes sense since there's always a risk of infection with open wounds. Instead, he applies an elastic bandage and schedules a follow-up. Dr. Casper sees her a few times after this, and at each visit, her leg seems to be healing quite well. But then by November 14th, things get a little bit worse. There seems to be signs of tissue death or necrosis on that blister. So Dr. Casper sends her to a dermatologist, hoping for some specialized treatment. Okay, then December the 2nd comes up. Things escalate fast. Mrs. Evelyn is celebrating Sinterklaas. It's like a Dutch Christmas in the Netherlands with her family when she starts feeling very unwell. Her daughter calls Dr. Casper's practice, explaining that her mother's leg is on fire, it's fire red, and she's shivering. And here's where things get a little tricky. Dr. Casper is on call that night, but instead of doing an in-person visit, he prescribes antibiotics over the phone. Mrs. Evelyn's son, who is also a doctor, isn't convinced that it's enough, and he calls back to ask Dr. Casper to come see his mother in person. Eventually, at 1:15 a.m., Dr. Casper goes out to see Mrs. Evelyn. He diagnoses her with erysipelas, that's a skin infection, and he prescribes more antibiotics. Unfortunately, by the next day, she's in an even worse shape. Her son takes her to the hospital, where she's diagnosed with a severe infection that spreads. Ultimately, that leads to her death a few days later at the hospital, and she dies from sepsis. All right, so now that we've got the timeline, let's talk about Mrs. Evelyn's son, who filed a complaint against Dr. Casper. He argued that Dr. Casper didn't do enough. His points were that Dr. Casper missed critical signs of infection, he delayed in-person care, and he should have insisted on a hospital admission much sooner. The son, being a doctor himself, felt Dr. Casper should have recognized how serious the infection was, especially with his mother's long history of steroid use, which made her more vulnerable to severe infections. And another bigger claim is that he felt Dr. Casper didn't handle communication well, both with the family and later on when the family tried to get the medical records. Now, in Dr. Casper's defense, he said he acted within reasonable medical standards. He claimed he prescribed antibiotics based on what he was told over the phone and that his in-person examination didn't reveal any signs that warranted immediate hospitalization. He also defended his choice not to open the blister early on, saying it was better to let it heal on its own to prevent infection. His attorney argued that even with a more aggressive approach, the outcome for Mrs. Evelyn might not have been different. And that's something we often see in these cases. It's about whether the doctor's actions were within the bounds of good practice and not necessarily whether a different approach might have led to a better outcome. So what did the disciplinary board decide? After hearing both sides, they found that Dr. Casper had indeed failed in some aspects of basic medical care. Specifically, they noted that he should have visited Mrs. Evelyn sooner and done a more thorough examination. And on that specific night when he prescribed antibiotics, he should have considered the fact that she was vomiting and that could have impacted how well she would have absorbed the medications at the time. So they issued a formal reprimand. Essentially, it's a warning, which stays on Dr. Casper's record. They noted that while his approach wasn't up to standard, it's not clear that a different approach would have saved Mrs. Evelyn's life. Let's take a second here to break down some of the medical terms we mentioned. For instance, erysipelas. This is a bacterial infection that affects the upper layers of the skin, and it's marked by red, swollen areas that can spread quite quickly. And then there's necrosis. That's when cells or tissues die due to lack of blood flow or due to infection. In Mrs. Evelyn's case, her skin blistered started showing signs of necrosis, which is why Dr. Casper referred her to a dermatologist. Prednisolone, another big factor here. It's a corticosteroid used to reduce inflammation, but it also weakens the immune system, making infections more dangerous. So let's dig deeper into how prednisolone and other steroids increase infection and sepsis risk in older adults. Let's look at the REGARD study. It's a study published in Critical Care in 2017, a large-scale analysis that followed over 30,000 adults for about a decade, and they examined how steroid use might influence the risk of infection and sepsis. Rather than just focusing on high-risk groups or hospitalized groups, the study found that even baseline use of steroids, whether oral or injectable, more than doubled the risk of severe infection among users compared to non-users. And here is where things get really interesting. Among those that did get a serious infection, the chance of developing sepsis, that's when an infection triggers a widespread inflammation that can lead to organ failure, was also doubled for those that use steroids. It's a strong indication of how steroids, which suppress inflammation, can make people even more vulnerable to severe infections. To understand this, let's talk about steroids like prednisolone and what it actually does in the body. Steroids work by dampening the immune system's response, which is helpful for reducing inflammation in chronic conditions like rheumatoid arthritis or even in asthma. But this immune suppression has a trade-off. It reduces the body's ability to fight off pathogens effectively. And the study explained that steroids interfere with multiple immune pathways. For example, they prevent white blood cells from sticking to the sites of infection. Steroids also inhibit the release of important immune signaling molecules, and it lowers the production of nitric oxide, which the body uses to fight off infections. Again, the REGARD study showed that over a 10-year period, steroids users had an infection rate of nearly 38 per 1,000 person years, while non-users had just under 14 per 1,000 person years. That's almost 3 times the rate. And even when adjusting for other factors like age and health conditions, the increased risk for steroid users was consistent. And this risk isn't just with long-term use. Interestingly, the study observed that the highest infection risk was in the first year after starting steroids, where the risk was actually 5 times higher compared to non-users. And it's likely that the immune-suppressing effects of steroids are strongest at the start, making early intervention and close monitoring crucial. What this means for clinicians is that, especially in elderly patients, they need to weigh the benefits and risks of steroids carefully. In cases like Mrs. Evelyn, who was on prednisolone for many years, regular monitoring for early signs of infection should be and is essential. And as the REGARD study suggests, minimizing steroid exposure when possible could reduce the risk. The takeaway here is that even though steroids are effective anti-inflammatory agents, they're not without serious risks, especially for infections and sepsis. Monitoring these patients, educating them on infection risk, and possibly tapering off steroids when feasible could be life-saving strategies. Now to wrap up, let's think about a couple of questions that might help us reflect on this case. Question number 1. In cases involving elderly patients on long-term steroids, what precautions should doctors take to monitor for infections? Well, in this case, regular monitoring or even a low threshold for hospital referral would have been quite important to think about, and a clear plan for follow-up, especially if infection symptoms arise, are extremely essential. Question number 2. When is it essential to prioritize in-person assessment over remote consultation? In my practice, generally, when it comes to elderly or frail patients, especially those that are on immune suppression medications, I will always prioritize a face-to-face visit over a remote consultation. Now, a face-to-face visit gives me the opportunity to not only assess the signs, but to make sure that I don't miss any other severe symptoms. And that can sometimes only take place after you've seen the patient, you've done your physical examination, and you've also spoken to the family members. I think it's important at that point that family members see you there. They know that you're taking the symptoms seriously, and there is a plan. What that plan entails can be either follow-up, and then the follow-up can be remote, because there's a plan happening. I can then follow up remotely. For example, I can call the family members and say and ask, okay, how is their mother, their father doing? And if I notice that there's a change in severity in the symptoms, then I can follow that through with a hospitalization or, in many cases, blood work. In this episode, I examined the case of Mrs. Evelyn and her family's complaint against Dr. Casper. I've gone through the events leading to her unfortunate death, and I've looked at the arguments from both sides and the disciplinary board's decision. Along the way, I've also discussed the importance of early intervention, the role of medications like steroids, and what we can learn as healthcare professionals. Don't miss out on another episode of Am I Mental? Doctors in Court edition. And if you have any questions, please let me know. Thank you.